I would suggest that as a physiotherapist, you have to respect what they are saying and how they are describing. They might say that something is crawling in my head,
Eyes are doing all this bouncy, all over in one particular direction. In this case, you can see the eyes bouncing, and this is in a response to an imbalance in your system.
Other presenter, now that we have been introduced to the different vestibular pathways and those that we might come across in our different practices as physiotherapists, we're going to be moving into understanding the process of rehabilitation. And this takes us to our next presenter, which goes by the name of Preeti Jedaya. She's on the list of participants. So let me just tell you a little bit about her. She has a 12-year experience in the field of physiotherapy, master's completed in neuroscience all the way back in 2012. She completed her vestibular rehab certification with in US of A, that's Austin, Texas, and she can practice in the states of Atlanta and Georgia. She has keen interest in treating patients with dizziness. So she has taken extra courses in cervical spine and concussion. She has now restricted her physiotherapy practice to treating patients with dizziness, vertigo, headaches, and imbalance. She owns a practice, Dizziness Rehabilitation, and she resides in the country of Canada, practicing in British Columbia and Alberta. She has certifications in competence in vestibular rehabilitation. She has introductory and advanced vestibular rehabilitation certification, level 1 certification in concussion rehab, that's level 1 and 2 in concussion rehabilitation. She has a R2P, and she'll explain all that to you. Post-concussion rehabilitation, injuries to the neck, that's acute concussion, and basic and advanced certification in adult NDT. So I'm pleased to introduce to you our next presenter, Preeti Jedaya.
Hello, everyone. Thank you so much for this introduction. It was a long introduction. I'm sorry about that. And first, I would like to start by appreciating how Dr. Channer has put like a foundation for us to take us into the next level of this presentation. Thank you so much, Dr. Channer. That was an amazing presentation. I loved it. I always keep looking for physicians and doctors and wanting to collaborate with them, because without them, we cannot function. It's very, very important. Before not taking too much of time, thank you, everyone. I think so that's Oshai, right? Thank you, Oshai, for that introduction. And I'm going to start with this. There might be some slides which look almost exactly like Dr. Channer, so I am sorry for that. But I will skip through those part pretty quick. So okay, let's get into. So today's presentation objectives we'll be trying to understand dizziness a little bit more, which Dr. Channer has already covered. Then we understand the functions of vestibular system and the role of vestibular rehabilitation. Some of the points, the first 2 points, we'll just skip through them pretty quick as they have already been covered. Now, why we are talking so much about dizziness? So like Dr. Channer said, dizziness is the mortal fear in physician. It produces mortal fear in physician. So it's the number 1 reasons for physician visits by the individuals over 65 years. And it is associated with functional disability and the risk of falls. These patients are terrified to walk. They're socially isolated. They will restrict their function. They will not go to work. They're just sitting at home. It causes them to become deconditioned. For older adults, it's a very high risk of falls. And we are, as physiotherapists, we are all aware of how falls can be detrimental to an older adult. And it can increase their mortality. So we don't want that. Dizziness like Dr. Channer said, it is described, it's basically an umbrella term for a variety of sensation. Now, just to keep to the basic, your patients are going to come and talk in very layman language, and they will really use variety of terms to describe their disease sensation. It is very important for us to understand what are they saying, how are they describing, because that can lead us to a probable diagnosis. So history taking is very, very important for us. These patients want us to listen. So you have to just sit back, do not ask them questions too much, just sit back and listen to them, listen to their story. And as they keep on describing their story, you will come to know what this patient is going through, how distressed they are, how anxious they are. They have gone into depression because of this dizziness. So all these psychological effect of dizziness will also impact in our rehabilitation further on. And there are a variety of terms described. I would suggest that as a physiotherapist, you have to respect what they are saying and how they are describing. They might say that something is crawling in my head, you know. These are the terms that I've heard the patient describing. Dizziness, it can come from head to toe. So any of these systems can give us dizziness. So we have to be careful. I always take dizziness as a red flag. When someone comes to me and says that I have dizziness, I always take that as a red flag and I go a little bit more deeper into it, because you may never know, the patient complaining of dizziness can have brain tumors, you know, just a simple symptom. I'm just dizzy, you know. A patient complaining of dizziness can have some cardiovascular problem, you know. So I just take it quite seriously. And when I take it seriously, patient thinks that they are being listened, they are being taken care of, and slowly and steadily you will start to see that they will start to respond to your therapy much better. Now, amongst all the causes of dizziness, this pie chart gives us a very good idea with subjects over the 60 years of age, how much does the vestibular system contributes to this dizziness. So Dr. Channer has described some of the terms. So first one was BPPV here, that's benign positional paroxysmal vertigo, that accounts for almost 32%. That's a big chunk of population, right? Then comes here is the vestibular loss, that's 13%. So we are almost 45% there, already there. The other part is fear of fall and disused disequilibrium. This is age-related changes. Around here we have a couple of other, so Meniere's disease accounts for 4%. It is little lesser than what they describe here, but this suggests to us that vestibular system plays a significant role, or vestibular disorders plays a significant part in the all causes of dizziness. How does this dizziness happen? Okay, so simply said, there is an alteration in the mechanism of maintaining the image on the image focused on the retina. So I'll give you an example for this. So what happens is, for example, if I'm turning my head to the right side, the speed at which my head needs to be turned, my eyes should also turn at the same speed. And if my eyes do not turn at the same speed, the image on the retina will not be formed and there'll be a slip, and what will happen is the image will be blurred or it won't be clear, and the patient will feel that something has moved or something they couldn't see clearly, and this will lead to the perception of dizziness. And like we know, dizziness is the distorted perception of the spatial orientation, right? So this is in the simplest of the terms to understand what would lead to dizziness. Berani Society, because it's an international society of all the special people, I would say. It's a neurootologist, scientist, researcher in vestibular rehab. They came up with the classification in 2009. That's called ICVD classification, and it describes all the definitions about dizziness, which is non-spinning, anything that's non-spinning, vertigo, that's dizziness, any sensation. Then we have vertigo. Then there can be vestibulovisual symptoms, and there are postural symptoms. Vertigo is a subset of dizziness. So vertigo is a special type of dizziness, or wherein there is an illusion of the movement of surrounding. So again, it's very important for us to understand from the patient how are they describing these symptoms? Are they having some vague symptoms, or they have specific spinning type of sensation? Now, in terms of vestibulovisual symptoms, there can be oscillopsia, which is the movement of the object, which is quite common in the patients with unilateral vestibular hypofunction or bilateral vestibular hypofunction patient. And then the postural symptoms, so balance-related problem, falls, unsteadiness, all those things. So these are the 4 cardinal symptoms described in the International Classification of Vestibular Disorder in 2009, and it's an amazing paper that they have done. Characteristic of dizziness, Dr. Channer has already spoken to us. So when we are taking the history, the most important thing I like to do is talk about the associated symptoms that they get. And one of the important part that I want to understand is, are they getting any auditory symptoms with it? Because if they are getting auditory symptoms, then probably I'm not just dealing with a simple BPPV or a unilateral vestibular hypofunction. I'm dealing with something more to it. So any kind of hearing changes, was it associated with hearing loss, any fullness? Is there any ear pain? Are there ringing, headaches? Is it affected by all these other activities? So like sleep, stress, allergies, any kind of activities or illnesses. So we have already talked about this. So that vestibular, this is where vestibular rehab comes. How can physiotherapists help the doctors here? Because a lot of these patients, they will end up in emergency, especially BPPV patients and vestibular neuritis patient, and unnecessary investigations are done, which is a healthcare burden to the system. It's a burden to the system. So we can definitely work a little bit hard. So physiotherapists have a lot of time to assess these patients, to sit and listen to their story, to come to a diagnosis, to rule out the red flags and send them to the GP, so that these patients don't land up in the emergency and do unnecessary investigations. And some of these patients, unfortunately, they don't even get the right treatment in the emergency. Now, this is I'm talking about the Canadian context. So probably in Jamaica, the context must be different. So don't take it literally. So we can help at least 50% of these patients and decrease the burden from our healthcare system. Now, what is the purpose of a vestibular system? It likes movement, our vestibular system, and it helps us to identify, or to gives us more stability, right? So it will estimate the body position and motion. It will help us to be oriented in space. And one of the other most important function of vestibular system is gaze stability. It's the ability of our eyes to be on target, or to be focused on a target. And this is this function is given by the vestibulo-ocular reflex, which Dr. Channer talked about. So your vestibular system and your visual system will coordinate with each other to give us this reflex, wherein if I move my head, are my eyes able to be on the target, or able to follow the target well or not? And it's motion dependent. These patients, when they get dizzy, they do not want to move. And when they do not want to move, the vestibular system gets this information that the person is not moving. Why should I function? So this is almost like a disuse atrophy that happens in them. And the other way I like to describe to this patient is in terms of neuroplasticity. So if you do not use this system, you're going to lose it. Okay. So then they get this information. Okay, I have to move. I'm going to get dizzy, but I'm going to get better. So I like to use a lot of neuroplasticity principles with them, so that they understand that it is important for them to move, to activate this system. Anatomy part, Dr. Channer has done amazing part in that, so I'm not going to go just a little bit. So there are components to this vestibular system. We have peripheral sensory apparatus, that's the inner ear, which contains the hair cells, which sends the information to our brain. So there's a central processing system. So we have got vestibular nuclei, we have got the cerebellum, and cerebellum is sort of like it keeps a check on your vestibular system, the information coming through it. So it's an adaptive processor and it will monitor the vestibular system performance if we need that movement or not. So it will correct and gives us the information for that. And then the motor output system. So the motor output system here is our extraocular muscles. So cranial nerve 3, 4, 6. Okay, so that will give us the vestibulo-ocular reflex. Then, as Dr. Chana described, vestibulo-cervical reflex, and then vestibulo-spinal reflexes. All of this is to get the gaze stability and the postural stability. Again, the anatomy part, I'm going to skip through it. Now, we'll come a little bit to the disorders of the vestibular system. They are described in 3 sections. Although I have only 2 here, I missed one part and then I realized, oh, I should have put that. So from where is the problem coming? So location of the lesion. So it can be peripheral, it can be central, or it can be mixed. Okay. As physiotherapists, we are more concerned about, we can help more. We should be concerned about the central part actually, but we are able to help more when they are peripheral vestibular disorders. The central vestibular disorders, we do play a significant role if a patient has stroke, multiple sclerosis, vestibular migraines, cerebellar tumors, post-acoustic neuroma surgery, all these things, we do come into picture after that when the medical management has been done. Okay, and the mixed picture, we have to keep that in mind. The mixed disorders of vestibular system, patient can have both central, so for example, stroke, plus they can have BPPV. Okay, so we have to keep that in mind as well. Now, in the peripheral disorders of vestibular system, it is described by how these disorders come about. So do they reduce the vestibular system function, or are they distorted, or they are fluctuating? Now, again, in terms of vestibular rehab, we can help significantly. There's a strong evidence for the distorted peripheral vestibular dysfunction and the reduced peripheral vestibular dysfunction. In terms of the fluctuating vestibular disorders, we will come into picture when the medical management has been done for these patients. So it is important to keep in mind that your patient might have Meniere's disease, perilymphatic fistula, superior semicircular canal dehiscence syndrome, etc. They will come to you. If they come to you directly, sometimes these patients can come, which I recently had a patient with brain trauma and post-traumatic brain injury, CT scan done, everything done, but her dizziness was not subsiding and she was getting dizziness with loud noises. So when the ambulance would pass by, her microwave would make sound and she used to get dizzy and very nauseous and vomiting. So when she came to me, I assessed her. I did a simple test that's called Tullio's phenomenon, and she was absolutely positive. So I sent back a letter to the physician. It's like, this patient probably has perilymphatic fistula. Kindly refer to the neurotologist there. So you might get these patients as well once you get deeper into the practice of vestibular rehabilitation. So we have to learn about these conditions as well. But our major role in terms of vestibular rehab will be in the reduced and distorted vestibular disorders. Dr. Channer said about, just one moment, I don't know how to get that up bar. So when we start taking the history of the patient, some things are very, very important for us to understand. So duration will play a significant role in our history and diagnosis. And why? Because there are some vestibular disorders, both central and peripheral, they have specific durations to it. So like BPPV, if something is lasting for seconds, maximum to a minute, okay, and it's positional and it's short duration and it comes only with, only comes in episodes, then we know that we are dealing with something peripheral related. It can be BPPV. So myoclonic dizziness, if the patient moves it, they gets dizziness with headache. Sorry, if the patient gets with dizziness with the neck pain and with the head movement, then it can be related to the cervicogenic dizziness. For the central vestibular dysfunction, I would like to point that the TIAs or transient ischemic attacks or stroke will last for minutes, okay, and they will be spontaneous. So it's very important for us to understand from the patient, did your dizziness episode or the vertigo episodes came spontaneously, like you were sitting and it just came out? And then was it associated with any other symptoms too? So we have to keep in mind the 5 Ds and 3 Ns. I hope you're aware of that. So dizziness, dysphagia, dysarthria, diplopia. I forget the last one, but that's okay. The 5 Ds and 3 Ns, so nystagmus, nausea, and I forget the third one, numbness. Yeah. So if the patient are complaining with these things, then you are dealing with something arterial, vertebropabasilar insufficiency, or stroke. So there are 4, so we have already talked about it, but we're just going to go a little bit into it again. So 4 manifestations of vestibular disorder. So your patient might come with these major complaints, okay? Vertigo or dizziness, nausea and vomiting will be associated with it because it causes the activation of medullary vomiting center. And this is a protective mechanism for these patients, for all of us actually. There's disequilibrium, there's imbalance. You have to understand if the patient has ataxic component to it or not, okay? And then the nystagmus, it's because of the impaired VOR that the brain is compensating by producing the saccades, okay? So we have to look for that part. Now I'm just going to show you, Dr. Channon has already showed, but I'm just going to play this video to see. So you look at this video and you'll come to know this patient is just sitting right in front of me. He's one of my patients. And he's not doing anything, just looking straight at me, and he has this nystagmus, and this is direction fixed, so it is only beating to the right side. And the nystagmus have 2 phases. One is a fast phase and the other one is a slow phase, okay? So if you look at this, you will recognize the patient has movement more towards the right side. So the fast phase is towards the right and the slow phase is towards the left. I'm going to play it one more time. So eyes go fast to the right, slow to the left, fast to the right, slow to the left. And then nystagmus is the nomenclature for nystagmus is done with the fast phase. So he has right beating spontaneous nystagmus, and this patient has acute neuritis. This is day 3 that I have seen him, and that's why he's still having these spontaneous nystagmus. Now, when I say spontaneous nystagmus, you would also be wondering it can come from central as well. Yes, that's right, absolutely. So spontaneous nystagmus can be central and only in acute peripheral injuries, so like acute neuritis or labyrinthitis. But the way we differentiate between the peripheral versus central is we would like to do a HINDS exam, which is head impulse, nystagmus, and skew deviation testing, which all the emergency doctors, they do it because they want to rule out stroke for these patients. So I did do testing because this patient came directly to me and he didn't go to the emergency. He was very dizzy, there was nausea, there was vomiting and stuff like that, but just came to me because the emergency wait is quite significant. So there was no skew deviation. The patients did start with intense nausea, vomiting, vertigo-like sensation, unable to get up from the bed, and very dizzy. And he had this nystagmus. So I checked him. I ruled out BPPV as well for this patient. There was no BPPV. And I just followed up with him. I sent back him to the doctor for the acute management. And then we started with the vestibular rehabilitation for this patient. And he has recovered in 6 weeks. He's fully recovered with his symptoms. Now, for the management of vestibular disorders, obviously there is medical management for it. Then comes the physiotherapy, and in the end, the surgery, depending upon what type of patients we are going to be having. Like Dr. Channer said, drugs, not very fan of, because our vestibular rehabilitation can be affected because of them, especially for the patients with BPPV and vestibular hypofunction, because we want our brain to adapt, okay? These vestibular suppressants commonly given here is Circ, beta-histin, sometimes Gravol as well. So these are the antihistamine drugs, which are vestibular suppressants, and they will suppress your normal side. Okay, and we don't want. So, for example, if a patient has vestibular injury on one side, so for example, right side has hypofunction and it has gone down, or vestibular loss. Now, brain is getting the asymmetric information when they're turning their head, when they're turning their body. What these vestibular suppressants do is they will repress the normal side as well. So at that time, when the patient moves their head, the brain is not getting asymmetric information and it doesn't let it adapt. So we have to request the doctor to stop those medication, explain the patient why we are asking them to stop these medication, and then let them know that we want your brain to adapt to the loss that they have got so that they can recover their function. And surgery, there are some conditions, definitely. So there will be acoustic neuroma. It's a benign tumor on the vestibular nerve. It's a slow growing, quite often missed, common in younger patients. And it will start, patient can start with dizziness, patient can start with vertigo, some hearing loss, slowly progressive disease. So post-surgery, vestibular rehab is very, very important for these patients to recover their function. Superior semicircular canal dehiscence surgery may or may not be. Perilymphatic fistula, definitely medical management, surgery needed for them. And no, I think so that's about it for them. In terms of injection, Meniere's disease, some patients might choose the option of killing the nerves by gentamicin injection, and that can give them the stable vestibular system. And once the vestibular system is stable, then the vestibular rehab can occur. And generally for Meniere's disease, vestibular rehab can be done in the late stages of the disease when they have complete hearing loss and the vestibular system is stable. They're not getting any more episodic, they're not getting any more episodes. So in terms of physiotherapy part, there's a specialization in vestibular rehab. You go ahead and take various courses and stuff like that. And then you get, because it's a scary field, I would say. It's very interesting, but it's very scary as well, because you may never know, when the patient is lying on the bed in the Dix Hall type position with the neck extended and rotated, they might get stroke, which doesn't happen. So 60% of making an accurate diagnosis is from the intake or interview. And Dr. Channer has stressed upon this quite a bit, and I really love that. You will understand from the patient's history what they are going through and what is their probable diagnosis right away. Okay. And then we have to review the medical history, gather information of their system, medical history, their occupation, their gender, and age is very, very important because vestibular diagnosis will fit in specific age groups. So BPPV is very, very common over the age of 60 years. And if you're seeing someone who's like 30 and 40-year-old, you should be thinking a little bit more, okay? That why is this young patient coming with BPPV? Is that just a one-off episode, or is there something else going on? Acoustic neuroma, very common in younger patients. Vestibular migraine, common in younger females, okay, in their reproductive years, okay. So you can actually delineate in terms of the age group of the patient as well. And if you find something fishy, do not hesitate to refer to the doctors. Simple bedside testing, very, very important. I'm going to just go through quickly with each of them. So Kamal et al. In 2011 suggested that 77% of the patients will be able to identify side and side of the peripheral vestibular lesions with just simple bedside testing. They do not require any equipment, okay? Just very simple tools, probably your finger, a pen, and just your hands in practice. That's about it. And some charts too, actually. So gaze stability test, you're checking the extraocular motor, you're checking the extraocular functions of visual tracking. Smooth pursuit. Smooth pursuit is the slow eye tracking movements. So you're also trying to rule out anything central, okay? So if there is a dysfunction in the eye movement when you're checking the smooth pursuit, keep that as a red flag. Okay. If there is saccadic eye movements that you're testing, so it's the fast eye movements. So you ask the patient to look from one point to the other as fast as they can. And if you see hypometric or hypermetric saccads, okay, red flag. Okay. Then comes to a very, very important test. We will go a little bit into it, further into the presentation, but just keep me so it's 9:30. We still have some time. Head impulse test. This test is very important, or it's also called as head thrust test. It will help us to determine if the patient has intact VOR or not, or vestibulo-ocular reflex or not. Okay. So you're holding the head of the patient, you're sitting right in front of the patient looks at your nose, you hold their head, and you quickly, it's a very small movement, you quickly shift their head. The patient's goal is to keep looking straight at your nose, okay? And you're looking at the patient's eyes. So when you give this little flick to the head, can the eye remain on the nose? If not, and if the patient makes this eye movement, this is called as corrective saccade, then that side is positive. And it's a good news because it's a peripheral vestibular dysfunction. Okay. If you find that the HINS exam is negative, the head impulse test is negative, patient has something called as skew eye deviation, where one eye is sitting up than the other, this is central. Patient probably has some kind of stroke. Okay. So these are some very important tests that we can do when the patient comes. We don't have to do all the tests, so you will come to know from the patient's history that which tests are necessary for me to rule out red flags for these patients. Dix-Hallpike test has already been discussed. All our standard balance tests. We, as physiotherapists, we are very good in testing balance, right? Your Romberg's test, Sharpen-Romberg, single leg stance, modified CAPSIP, so modified clinical test of sensory integration, testing them on ground, testing them on foam, how are they walking, walking with head turns, are they able to keep, are they able to be on the straight line or not, are they drifting to one side, which side are they falling off. It's a very simple test, but it can give you immense information. Dynamic visual acuity, again, a part of the gaze stability, wherein you are asking the patient to read an eye chart in the static position, and then you move the head. And we ask the patient to read again and see if they are able to read the lines or not. If not, then they have impaired gaze stability. Subjective visual vertical test, it's a simple test. Actually, there's a machine test and then there is a bucket test. So physiotherapists have developed, I think it's a physiotherapist, they have developed a very simple test to test it with a bucket, and this will give us the verticality of the patient or not. Okay, so does the patient see their reference point as straight, or they see it like this? Most of our stroke patients will have their reference point altered. Okay, quite a few BPPV patients, I don't exactly remember the percentage of it, but BPPV patients and vestibular hyperfunction will also have off verticality. We've discussed about BPPV. Dr. Channer has already talked about it. So it's just a mechanical disruption, okay, of the displacement of otoconia or the crystals from the utricle into the semicircular canal. It never comes out from the saccule though, okay, so remember that. Utricle is directly connected very close to the semicircular canals, so that's where the crystals will slough off and then they will go into the canal. Now the way they are positioned, posterior semicircular canal has the most prevalence. So it's 85 to 95% of the cases will be of posterior canal. And there are two types. So there is canalithiasis and there is cupulolithiasis. Canalithiasis meaning free-floating crystals, and cupulolithiasis meaning they are stuck into the cupula. Okay, cupulolithiasis are, I would say, rare, like they're, and they take a little bit longer time to get better compared to the canalithiasis. Okay, the next common BPPV is lateral or horizontal canal BPPV. It's around 5 to 15% of the cases, and the anterior canal It's extremely rare, excuse me. But if you imagine, this is where our anterior canal is, so like they're up. So gravity should take care of the crystals if they go into there, okay? So the most common in physio practice, what we see is posterior or the lateral canal. Off chance, you might see an anterior canal BPPV. Testing of BPPV, the standard test is Dix-Hallpike test for diagnosing anterior and posterior canal BPPV. Now, how we diagnose is there a specific type of nystagmus pattern that these canals will follow. Okay, so if it's posterior canal, now it's getting a little bit too much, so I'm just going to quickly go through this. There is upbeating and the torsional nystagmus that we see in posterior canal. For anterior canal, it's downbeating and torsion. Okay, just remember that for now, but as we go in future for more presentation, we can go into more details of this. The other test that we do is roll test for horizontal canal, because these canals are like this. Okay, so you can't do Dix-Hallpike to diagnose the roll test. Okay, sometimes you might find some type of nystagmus in the Dix-Hallpike position, like the horizontal canal nystagmus, but primarily it will follow the pattern in the roll test. So simply the patient is the patient is lying down with a pillow under their head. In this diagram, it doesn't show it, unfortunately, because the head needs to be 30 degrees up. The patient rolls to one side, you watch their eyes. The patient rolls to the other side and you watch their eyes. Now, these patients will show a classical pattern of nystagmus that's called as horizontal nystagmus. So their eyes will beat only in this direction. There is no torsional component and there is no upbeating or downbeating component. Okay. As you go into the deep depth of vestibular rehab, this is the primary thing that we learn, we see, and we sort of like understand in terms of diagnosing these horizontal and other canal. So I'm just going to show you Dr. Channer has already shown, I'm going to show you one more time. This lady, 34-year-old, she is a teacher. She's a school kindergarten teacher, and she was partying. So see, this is young patient. She's 34-year-old. Okay, so when she came to me and she said that I get these vertigo, I was a little suspicious. Like, what happened exactly? What happened to you? And she said, nothing. I was partying. I got drunk and I fell and I hit my head. So trauma is one of the major causes of BPPV in younger population. Okay, so head traumas. So remember that if the patient is coming. And the other one is the vestibular migraine. So at around 3-minute mark, I will take her into that Dix-Hallpike position, and you will see that classical short duration right beating. Right torsion upbeating nystagmus, which will start soon, and it will come fast, and then it will slowly, so right there. So if you see the eye movements, so it's very classical torsional movement, and it slows down. So this is very, very classical of BPPV, wherein there is a crescendo and there's a decrescendo pattern that you look for in these patients. It's short duration, it's following a pattern. So I was like, okay, this is what you have, BPPV, let's do the Epley's maneuver. And she was better in like 2 sessions. She got recovered in 2 sessions. We were discussing about the head thrust. This is very, very important test. You have Dr. Channer there. Ask him to teach you. This can give us immense information. Okay, and the more you practice, the better it gets. Okay? So we've already discussed about it, so we're not going to go again. Now, so this is the head thrust that I did on my previous patients. So if you look at this, I thrusted his head to the left side, and you see that corrective saccade. So his eye moved from left to right. If you can appreciate that, I'll play it one more time. So this was so when I tested that, I was sure that, okay, this patient doesn't have stroke. His head thrust is positive. It's left-sided vestibular neuritis, and I'm going to start with his management for vestibular rehab, and I started with him. Now, what is vestibular rehabilitation therapy? It is purely exercise based. It is highly evidence based. Any literature that you open up on vestibular rehab, most of them will have very strong evidence towards the therapy for these patients, treatment for this patient. Okay, so if any patient doubts, just give them the articles and let them know that it has strong evidence, very well researched. Okay, you will never find, you will not find not an article on vestibular rehab supporting it. Okay. So what is the idea behind this vestibular rehab? So what are we trying to do? So we are trying to promote vestibular adaptation and substitution. Okay. So substitution is for the patient who have lost completely. We are using different mechanisms to help them. Adaptation, patient has lost the function partially, and we are letting the brain adapt to that lost function. Okay. It helps in the recovery of gaze and postural stability. It helps in alleviating the vertigo, positional vertigo we are talking about here. Okay, so your BPPV patient should get completely resolved. Okay, it helps in improving the ADL, helps in decreasing the falls, balance rehab. We all know, we are all very good at it. And we have seen that supervised 1 per week for 6 weeks balance training has shown immense result in like better and decreased falls in patients with in older adults, right? Now, vestibular rehabilitation, although it has some limitations, but it is effective in patient diagnosed with vestibular disorders in which there is a fixed or persistent deficit. So if you remember that slide that we were talking about the 3 disorders, so there was distorted disorders, then there was hypofunction disorder, and then there is a fluctuating disorder, right? So if the deficit is not fixed or persistent, then our vestibular rehabilitation will have the limitation. Okay, so here as physiotherapists, we have to understand that we cannot treat all vestibular disorder patients. Okay, in terms of vestibular rehab, so I'm very specific. Okay, so I can't give gaze stabilization exercise to a patient with Meniere's disease when he's having the acute attack. It's not going to work. Okay, now during that non-attack phase, can it work? No, because during the non-attack phase, it comes back to the normal level, right? So there's this fluctuation of the symptoms of these patients. Okay, so we have to understand here. It will definitely be effective in patients with positional vertigo, cervicogenic dizziness, very important part. I should mention one more part here, that's concussion. So post-concussion symptoms will have, one of the symptoms is dizziness as well, because the vestibular system can also get affected, and vestibular rehab is very effective in these patients as well. Clinical guideline 2021 for unilateral and bilateral vestibular hypofunction has suggested strong evidence for vestibular rehab both in acute and in chronic stage. And in acute stage, you can start the rehab as early as 3rd day. If the patient is stable meaning if the patient feels a little bit okay to talk to you, to understand, or if you get the referral that sooner. Okay, generally these patients won't come to you that soon. But if you get the chance to see these patients 3rd day, 4th day, you can start the rehab that early for these patients. Especially Susan Herdman and her group had done the studies on post-acoustic tumor neuroma resection patient, and they started the rehab 3rd day, and they have got pretty good results in the recovery of these patients. Treatment strategies. The first important part would be for us to educate these patients. So when they come to us, when you come to a conclusion that, okay, this patient has BPPV, or this patient has hypofunction, or this patient has vestibular migraine, or any other condition that you suspect that the patient has, you're supposed to educate them. Once they are educated, they will feel that they are heard of. Okay, they will feel that someone understands their problem, because most of these patients will think that everything is their head. It's all psychological, right? They're making it up. Their family members will think that this patient is like, they are making it up. Okay, and a lot of physicians also will tell the patient that it's all in your head, it will get better, as time goes on. But it is not like that. Okay, so there's a stigma attached to this dizziness, and we have to break that stigma for these patients. So educating them, assuring them that vestibular rehab can help, exercises can help, and you can get back to your function, and etc. The next part is canalith repositioning maneuvers. Okay, now we have 3 canals, and there are ends and ends a number of maneuver that you do to take care of these patients. I think so every couple of years there's a new maneuver that comes out. It's good as well, but we'll stick to the basic. So if you did a Dix-Hallpike test and you got posterior canalithiasis, the standard maneuver that we start with is called as Epley's maneuver. It was given by Dr. Epley's. I always forget the day, the year. I think so it's 1972. I think so, but I may be wrong. So don't quote me on that. And it's a very simple maneuver that he said, like, so it's a body position. So we will use the help of gravity to reposition these particles. And it will look like this. Now this diagram shows that the patient is doing on their own, and patient can do on their own. Okay. But when they come to your office, if they're very scared and they can't do, obviously we will do it for them. So basically the patient is sitting like this. There's a pillow behind their back. The therapist is standing by their side, holding their head. They turn their head to the side of the lesion or to the side of the problem. So this patient is doing the left Epley's maneuver. So the head is turned 45 degrees to the left side. The patient lays on the back. The head goes into a little bit of extension. 30 degrees of extension is good enough. And then the next is you wait here to see any nystagmus, any symptoms coming in, plus 30 seconds. Wait for it to subside. Then passively rotate their head to the other side. Okay. So when you passively rotate the head to the other side, the crystals will start flowing in the opposite direction from where they are stuck. Okay. Again, you wait here. If there is any symptom, that's okay. If no symptoms, wait for plus 30 seconds to 1 minute. Then the patient roll onto the side with chin tucked in, and this position will help. Oh, they're missing one position actually. And this is the position. This is a very important position because right here in this position, the crystals will flow back into the utricle, and then the patient comes to sitting position. Now here he comes back to the long sitting, which we don't recommend. The patient comes to the sitting position, and you support the patient. It's pretty simple. So you see how simply those particles can be put back in positions. Now for horizontal canal, there are different maneuvers. That's called barbecue roll or 360-degree roll. There are other maneuvers as well for cupulolithiasis. There are other maneuvers. We're not going to deep because we don't have time to talk about them, but just to let you guys know how we can help these patients. Okay. Then the other one is the adaptation exercises. So adaptation exercises are for gaze stabilization. Okay. Simply speaking, the patient is looking at a target and they're shaking their head. They have to shake their head at a specific speed to get the adaptation to happen. Okay, not too slow, fast, it is going to make them dizzy, but they have to control the speed. They have to do it repetitively throughout the day. So at least the recommendation for the acute patient is 3 times a day for minimum 2 minutes each, up to 10 minutes per day. That's for acute patient. For chronic patient, it can go up to 20 minutes per day. Okay. Substitution exercises is we use other mechanisms. So like we use saccades, we use the smooth pursuit mechanism to help them substitute for the lost function, for the complete loss of function. Habituation exercises are for the patients with motion sensitivity. Okay. For example, I don't have any problem. Like when I'm looking at the target, I'm fine, no problem. I don't get oscillopsia. Okay, meaning that the object is moving. I don't get that. But when I suddenly move my body, I just feel that fraction of a second. I feel that sensation coming in. Okay, at that time, what we recommend to do is we just recommend these patients to do these habituation exercises. A very common and famous exercise is Branderoff exercise for the habituation. We generally don't give branded of exercises. We customize it to the patient, okay? And it's any movement that are making them dizzy. We let them repeat a couple of times during the day. And then the brain will start to habituate that movement. There is also the component of visual motion sensitivity. So we have to ask the patient, are they having only head motion sensitivity or body motion sensitivity, or they have visual motion sensitivity as well. The visual motion sensitivity, we give them visually challenged exercises. So they're not moving legs, images, okay? We start by simple images and then they go to complex images. So if you remember the slide where Dr. Channer put in this 3D image, which was coming to us, we use those type of images for these patients with visual motion sensitivity, and you let it habituate. Balance exercises, very standard. We all know about it. Gait training. There's visual vestibular integration. So once you have settled down your patients, doing that, then we add the integration of visual and vestibular system. Physical conditioning, very important. You have to make these patients get out from their home, okay? Get out of their bed, do some chores, get out, go for walking, okay? Use a stationary bike. You have to get them because they're so physically deconditioned. They're not moving their head, they're not moving their body. They're walking like a rock, like a stiff, like a robot, okay? They lose their postural stability. So we have to get them walking, and that also helps improve in just general, because these patients can get very depressed, can get very anxious, they can get panic attacks, okay? There's a lot of psychological overlay in them. So we have to, as they get going, as they get moving, then obviously the hormones are the good hormones, the endorphins will help them decrease their depression, decrease their anxiety, and they'll be more functional. Vision exercises I have put down here, that is also positive part of vestibular rehabilitation. We use this specifically for post-concussion patients. It's just targeted vision exercises. Cervical repositioning training, very important. Dr. Channer mentioned very well about how the cervical spine or cervical spine helps in sending the information to the brain, the impulses. So upper C spine has immense amount of proprioceptors there, the ligaments and the muscles that sends the information. And if they have neck pain, if they're keeping their neck very tight, it's a reflex spasm that they're getting from their vestibular system because they're protecting. These patients will get cervicogenic headaches, neck pain, dizziness, and then the vicious cycle keeps going on. So we have to help them. We can do manual therapy. Absolutely, go ahead with that. Do the manual therapy. IMS dry needling to help relieve their muscle tension. And then the neck exercises, plus also the repositioning training. It's a beautiful training actually. You check the joint position error sense by keeping a laser head pointer on their head, and they're looking at a target, they're keeping their eyes closed, and then they move their head and then bring it back to the same target and see how much the positioning error they have, and then they work on that. I love the last one exercise, believe me, surface orientation or grounding exercises. Very, very important part in vestibular rehabilitation. I find this as the mainstay of my treatment. Okay, now why? Like I said, these patients are very anxious, their nervous system is on fire. So we have to calm down their nervous system for any neuroplasticity to happen, okay, for any changes to happen. Surface orientation or grounding techniques, it's almost like a mindfulness training or meditation training, but I use the term these because a lot of patients get scared when they tell them, oh, you have to meditate, they don't like it. So when you tell them that you are grounding yourself, you are using your somatosensory inputs to reorganize your system, okay, and that helps them significantly, okay. So please use this technique in your vestibular rehabilitation. Now there are some factors that can affect our treatment efficacy: positive influencer, negative influencer. We'll talk a little bit more on negative influencer here. Generic unsupervised exercises, okay. A lot of these patients will go on internet and they will download a generic exercise. Some may get better, some may not get better. They'll have delayed recovery. Rather, giving a customized, supervised exercise program is much more better in the in the treatment recovery for them. Fluctuating disorder, we've already spoke about that. Head injury, dizziness is a negative predictor of recovery in head injury. So if these patients have dizziness and head injury, they might, but it will take time. Mixed central and peripheral region, this is generally, it takes a long time for recovery. Stroke plus BPPV, your BPPV will recover. Stroke will take a long time. We all know that. Multiple sclerosis, patients can have BPPV, again, same thing. Vestibular suppressant medications, we've already talked about it. It depresses the normal vestibular function and it affects our recovery. So we have to start the program as early as we can, okay? Then we can have better and faster recovery. Like I said, day 3 post-acoustic neuroma surgery. The patient is with all the surgical bandages and everything, and you're making them exercise, right? So for vestibular rehabilitation, it's a cornerstone of treatment of many symptoms of vestibular loss. It's effective in reducing symptoms of dizziness in patients with long-standing vestibular loss by 85%. It's never too late to start vestibular rehab. I have seen patients coming to me after 2 years. I've started with them and they do show recovery, okay? Obviously, it should be started as the acute stage of nausea and vomiting has ended. So I feel that the doctors should prescribe more so like an anti-nausea medication to them rather than a vestibular suppressant, and that can help. Some simple things like ginger gravel or just ginger will help reduce their nausea and vomiting. And what I've also noticed, if the patient has a lot of nausea and vomiting, I start my session by teaching them surface orientation. So as soon as they relax, their nervous system knows that they are safe, they're at a safe place. They will automatically calm down and their nausea will subside. So try this. If the patient comes to you in a pretty acute stage, acute BPPV, very nauseous, don't go directly into the maneuver yet. Teach them surface orientation, get them to calm down, and then you do your maneuver and then follow it up again with relaxation, okay? We have to make the patient understand that these exercises will increase their dizziness. So whatever makes you dizzy, whatever makes you a little bit dizzy is good for you. So that's a vestibular rehab mantra that I like to keep telling them. And this is necessary for the compensation to occur. So what is the key to our success for vestibular rehab? It's timely diagnosis. Diagnosis is very, very important for us. You cannot start your vestibular rehab until you have a firm diagnosis, because if it's a fluctuating disorder, it can give us trouble, or we can make the patient's condition worse. So for example, if the patient has vestibular migraine and we are teaching them vestibular rehab exercises like gaze stability and they're getting very dizzy, it can aggravate their symptoms. It can make their condition worse, okay? Awareness and education, always, we know that. We have to customize their treatment plan. We cannot give them, those downloadable handouts from the internet. Customize it for each and every patient. And you have to customize them in terms of their return to work as well. So if there's a teacher who bends down constantly up and down to teach their kindergarten kids, so you have to customize that. If there's a chef, or like Dr. Channer said, for pilots and all these. So you have to customize the patient customize the treatment plan according to them. And then appropriate referral if needed. If you cannot handle these patients, refer to someone who can take care of them, to a senior vestibular physiotherapist, to collaborate with all the doctors possible. So you will need in your team definitely a neuro-otologist, general physician, sometimes neurologist, for migraine management, audiologist. I really form a good team with audiologists, because I know if there are some tests, I will do bedside hearing tests that I do, like Renee test and Weber test. I make sure I do on my patients to rule out if there is any hearing loss. And if I find something like that, then I send it to my audiologist, and they will do the audiology exam, and they will let me know what type of hearing loss that they have, if they have a low frequency hearing loss. And if I'm suspecting that the patient is showing episodic pattern, then I suspect that the patient has Meniere's disease, and I will refer them to the ENT or neurologist for further management. So these are very, very important team members that you need to have in your team for as vestibular rehab goes on. These are my references, and thank you everyone for listening to me patiently.
Okay, thank you, Preeti, for that interesting presentation. I'm sure that a lot of persons have been made aware of, I hear of physiotherapy care that we can delve into. We're gonna go to any questions, whether from my in-house audience or from the virtual audience. If you have a question, we're gonna spare a few minutes for you to just put them in the chat. And whilst I'm at that, I know a few persons have been requesting or sending requests for the presentation. I'm gonna ask Preeti, while she's here, if she's okay with sending the presentation and we'll distribute it. Is that okay for you?
Yes, that's fine.
So we will have that done for those who would want to have that as a refresher for themselves.
Yes, absolutely.
All
This
right,
was
so
just an overview because we have very less time. Vestibular rehab is a very in-depth field itself. So this is just an overview, just to touch upon a few things.
very well. So if there are no questions, we just want to say thank you for the participants. Again, there was a link placed in the chat as regards to the Google form. You can fill that out and we'll provide you. Well, there's a question.
Yes, there's a
I think
question.
that's coming from Adrian Palmer. You can go ahead, sir.
For postgraduate studies. Adrian, can you ask the question? Can you unmute and ask the question?
Hi, good afternoon, everyone.
Good afternoon.
Thank you again for your presentation. Thoroughly enjoyed it. It was very mind-opening. Learned a lot. Probably won't remember everything, but for persons who may be interested in going further into vestibular rehabilitation, what programs would you recommend, or what training institutes would you recommend?
So for vestibular rehabilitation, there are a couple of programs that are done. One is Duke University's. So it's a certificate of competency in vestibular rehab. It's a 1-week course, okay, in Atlanta. They have what do you call? They want you to be in practice. They want you to do some basic vestibular rehab courses first. Okay, they can be weekend courses. Okay, once you do those weekend courses, they want you to be sort of like practicing for a couple of years, and then they want you to take that 1-week course in Duke. It is one of the standard course that most vestibular physiotherapists will take. The approximate cost for that in terms of Canadian currency is $5,500 Canadian dollars. That's what the price of the course is. It's an in-house course, so you stay there in Atlanta for 1 week and then you learn about vestibular rehab. The other course, that's an advanced physical therapy program in vestibular rehab in University of Pittsburgh. It's online plus in-person course. It's, I think, so 3 months long course, you know. The price is approximately the same, but again, everyone recommend that you do a weekend course first, a 2-day course, and then you practice, you see a lot of patients, and then you go into these advanced courses to learn. So I didn't take my Atlanta course until this year actually. So I've been practicing since 2017. 2017 was when I took my basic course by a local instructor here in Canada. I did that, and then I practiced the vestibular rehab for a couple of years, and then I started applying for the certification. There is another certification course, let me see, Florida. It is by AIB, American Institute of Balance, but by Dr. Gans, I want to say. He's an audiologist who takes these courses. Again, pretty expensive. It's an expensive field, but yeah, but worth it. Yes. Any other question?
Thank you so much.
You're welcome. I also want to know from all you guys that how many patients do you see in your practice for vestibular disorders?
So just to answer that question as best as I can, to be honest, we don't interact with a lot of patients referred for vestibular rehabilitation, but we have a lot of neurological cases that we interact with. Of recent, we're seeing more cases being sent to us from the ENT clinic and departmental institution for vestibular rehabilitation. So it has now become a new area of interest. So we have a few at the clinic that we're interacting with now, except that in the past, we didn't have that much. And here from the chat, my manager is saying to us, we have at least 5 per year. So that's about on average what we see.
Yeah. No, that's very good actually. Somewhere to start, right? And as you get into the practice of it, then you will get more and more referrals. So collaborating with ENTs, and you have a neuro-otologist. So that's very, very important person that you have. And he really understands about dizziness part, because lots of ENTs, they are only dealing with the ear, nose, throat, surgical cases, right? But they do not deal with dizzy patients. But neuro-otologists are specialized into the dizziness and vertigo part. So it's very important to collaborate with these doctors, and it's really helpful. And so there was a question here.
Yes.
How long would a rehab program for these set of patients last up to discharge? So for BPPV patients, it's generally 3 to 5 sessions. That's about it. So maybe in a week up to 2 weeks, these patients should start to feel better or no symptoms at all. For the patient with hypofunction, it can last up to 6 weeks to 3 months for these patients, and they should start to see recovery as early in the first 6 weeks. So the patient that I was discussing, the videos that I showed you, he recovered in 6 weeks because I started very, very early with these patients. There was a part that I did not put in. There's something called as chronic dizziness. And these are the chronic patients that can take up to a year. And there's a category that called triple PD or functional. It was called functional dizziness before. Now it's called as persistent postural perceptual dizziness. These are the patients, this is the complication of the other vestibular disorder where the patient will land up into this chronic dizziness pattern. They can take up to a year. Okay. So there's a very good website which is being called, it's called vestibular.org. I will just put that here. It's a non-profit organization in the US created by the patients in the US, and now it has all the practitioners, healthcare directory and everything. They've got pretty good handouts and information about most of the vestibular conditions. In very simple terms, they have laid out very good. It's pretty good to give out the handouts from this website to the patients or redirect them to this website. I'm a member of that website, that organization as well. It's called VIDA, Vestibular Disorder Association. So all the physiotherapists, vestibular physiotherapists should be a member of this organization. It's very, very helpful. And if you guys have any questions coming up, just send it to O'Shea and then he can send it back to me and I'll be happy to answer you guys.
All right, so that looks like it from us this morning. We want to say again, big thank you to our presenters. Thank you to the virtual audience that would have joined us. And I hope that you have learned a lot from these sessions. We hope to continue them as we go, and for sure, once we have them planned and been executed, we'll definitely extend the appropriate invitation. So once again, thank you, Dr. Channa. Thank you, Preeti, and we'll see you next time.